still do the midterm on Sunday.
Yeah.
10 inches total, which is nothing.
I think it's all the way.
We used to get 2 or 3 feet and still have school. Now people go, we're a couple inches. So I used to walk to school uphill both ways. You don't believe me?
Across a river.
Nope. Kind of a mini San Francisco, Dunsmuir. And it is uphill both ways.
What?
Yeah.
Is it also downhill both ways?
There is downhill both ways also. So yes, there is. I can honestly say I walked uphill to school both ways, to and from school every day in the snow. Well, it didn't snow every day, but I walked every day.
Every day, back when it snowed in July.
It's still here in July.
The day I was born, it snowed on the 4th of July. That was when I were a little kid.
Was it in 1994, was it? The 94, I was on a structure fire here on Union Street in Weed on the 6th of July of snowing. All right. We already did chapter 50. You were talking and you missed it. Any questions? All right, we're starting respiratory emergencies. Don't hold your breath. Thoughts of the day. This is not a field for everyone. If you pass this class and become part of the EMS community, you are in less than 1% of the percentile. You'll become part of a unique group of people that has excellent critical thinking skills and the ability to work under high stress situations. 99% of the people can't do that. The EMS population is less than 100th of a percent of the population. So never sell yourself short. If you're here and you're doing this and you make it happen, it's a huge accomplishment. Hopefully that will encourage you to study for exam 3 in your midterm. They're coming up rapidly. All right, so we're going to review the anatomy of the upper and lower respiratory system in the airways. Since you've already done that, it's a review. And the physiology, which is also a review. And then the new things we're going to do is go over the types of respiratory emergencies and their treatments. And we're going to go over the 5 different types of breath sounds and the disease process associated with them. Then we're going to go over the generic names and forms of medications. We're going to go over the considerations for influenza A, which is the leading killer in upper respiratory viruses, and understand the difference in priorities of pediatric versus geriatric respiratory emergencies because they are huge differences. Any questions about the objectives of this class? All right. Get tired of seeing that picture? Good. No. You have it memorized by now. It's like the 20th time you've seen it. All right, anatomy and function of the lung. Remember, goes down to 1 red blood cell at a time. Comes down through the pulmonary artery, deoxygenated blood. Goes down to the alveoli. 1 red blood cell at a time goes in, exchanges that carbon dioxide atom, grabs an oxygen atom, goes back to the pulmonary vein of the left atrium, down to the left ventricle, pump back out through the aorta to the cells. Any questions? Goes to the cells, exchanges that oxygen for a carbon dioxide atom, goes back to the venous system, up through the vena cava, back into the right atrium, through the right ventricle, back down the pulmonary artery, back into the lung. Exchanges again, goes back up to the pulmonary vein, so on and so forth. Any questions? It's the ultimate recycling system. All right. Again, this is a review. Do you have any questions on what it's like to breathe adequately? Any questions on what it's like to not breathe adequately? So we're going to go over this. Pulmonary vessels being obstructed, damaged alveoli, airway obstruction, fluid in your lungs, pleural space crushing the lung, whether it be air, blood, or pus. Any questions? Yeah, sure.
What's up?
Oh, we're just going over, looks like it's not breathing correctly.
Stop.
It's not fun.
Unless it's a sucking chest wound.
Yeah. Get it? Kirk made it funny.
Dad jokes. Still have a full class. That's all.
Yeah, it looks on everything.
You have a full class. Everybody's doing well.
Well, we'll see. Exam 3 is Thursday night and the midterms on Sunday. Midterms, the big final, that's when they know if they're gonna pass or not. Yeah. It's on trauma. We're just ahead. There might be a few respiratory questions on the midterm. Shouldn't say that.
Sweet. And then hopefully they all pass and sign up for the medic program.
Exactly.
Because I'm capping the medic program at 30 students.
And there's nothing but EMT and paramedic jobs out there available. Everywhere you look.
That there is. All right, sweet.
All right.
Have a good night.
We'll see you guys on Thursday. Any questions on signs of inadequate breathing? How do you know when the lungs are feeling inadequate? Breathe too slow, too shallow, patient turns blue, unresponsive. When your respiratory system has a feeling of inadequacy. Any questions? Dyspnea is a vocabulary word you have to know. It means shortness of breath or difficulty breathing. People are down to only able to say one word when they take each breath. That's not an adequate breathing. You should be able to speak a whole sentence without taking a breath. Any questions? That's an important assessment finding.
Just be what we write on PCRs or like.
Oh, yeah.
Okay.
Patient complains of dyspnea. Onset. This lady has dyspnea 24 hours a day, 7 days a week. Says she's got pursed lip breathing. Says she's got accessory muscle usage in her shoulders. And if her bathrobe was open a little bit more, you can see it in her clavicles. She'll be like that for the rest of her life. She has COPD, which is chronic obstructive pulmonary disease. Millions of people have it. You will go on lots of calls. These are the things that could cause dyspnea. Upper and lower airway infections are huge right now. Everybody's getting it. It's like a real popular thing to happen. Way past what we're reading. Acute pulmonary edema, that's when the lungs suddenly fill with fluid. COPD, chronic obstructive pulmonary disease. That includes emphysema, chronic bronchitis, chronic asthmaticus, and black lung. Asthma, allergic reactions, anaphylaxis. A collapsed lung also has pneumothorax. Pleural space filled with fluid or pus called pleural effusion. Having a seizure that doesn't stop. Having something blocking your airway will cause dyspnea. A blood clot in your lung that stops blood flow through your lung will cause dyspnea. Environmental exposure, if you inhale a bunch of smoke or carbon monoxide, that will absolutely cause dyspnea. And of course, any type of bacterial or viral infectious disease. Any questions on what can cause dyspnea? Oh boy. Upper and lower airway infections. These things are gnarly. Cause us to lose a whole year of classrooms. Dude, we're terrified of upper respiratory infections. Some questions? So types of airway infections, epiglottitis. Remember the epiglottis, that flap of skin that protects your airway when you swallow heat, food, and water from going down to your airway. Well, if it gets infected and swells up, it'll block your airway, which is a very bad thing. Then we have croup, which is generally in children, same with epiglottitis. It's an upper airway infection. It causes a stridorous sounds and causes a seal-like barking cough. You go, hark, hark, with a cough. So you can test croup in the field as an EMT, see if the child can spin a beach ball on his nose, then you absolutely know that it's croup. Respiratory syncytial virus. That one, so respiratory syncytial virus is, you've probably heard it abbreviated as RSV. It's always been deadly for children because they don't have strong enough airways. They can't cough the amount of mucus and junk that it creates. But in adults, it was always just basically a common cold. Well, after the COVID-19, which was the COVID virus, is a common cold. COVID-19 is the common cold. There's been COVID-19 every year with common cold virus before it was 500 times more contagious, and went 500 times higher than the common cold that killed elderly people, overweight people, and immune compromised people like crazy by the tens of thousands. But now we have a super RSV virus going through. It hasn't got the media's attention, but it's happening. And we have elderly, overweight, and immune suppressed adults are now dying of RSV, just like we died of COVID-19. But it's another one of those viruses been out there forever, but now suddenly it's hundreds of times more contagious and deadlier. Yes.
So is it that it morphed or that we were like insulated from a lot of virus infections?
Nobody knows.
No.
In the history of the world, viruses have not morphed hundreds of times over by themselves, unless they've been genetically altered. Yes.
Is it resistant to meds?
RSV is a virus, so there is no medicine. Okay. So there are no medications for viruses. There are only medications that relieve the symptoms of viruses or prolong the inevitable block. Like right now, Paxlovid is the big thing for COVID. It does not cure COVID. It will reduce the symptoms and lessen the effects of it, but sometimes, majority of the time, when you're done with Paxlovid, it comes back in full force. The COVID does. Any questions on RSV? Then they got pertussis. Pertussis, before the vaccine came out, for it was killing hundreds of thousands of people, wiped out entire tribes of Indians. American Indians, when the Europeans first came here, because they had no defense to it, just wiped them out. Was still killing people worldwide until about 70 or 80 years ago. They came with a vaccine, and then they almost had pertussis completely eliminated, wiped out. Then people stopped vaccinating, and then now it's making one hell of a comeback. It's called the whooping cough. It's the common name for it. When you cough, pertussis, it sounds like a whoop. Then we got SARS. SARS was a big thing about 10, 15 years ago. Came over from Asia. I can't remember it's an acronym, I can't remember. It's Serious Asian Respiratory Syndrome or something like that. Serious Acute Respiratory Syndrome, something like that. However, the old standard, it's still 2020 was the only year it wasn't the leading killer. The leading killer every year, the champion though, is influenza A. Influenza A kills more people every year than any other respiratory virus. It took a year off in 2020, but COVID was the new king, but now influenza A is back up. And then of course, yes.
What is influenza?
It's a respiratory virus. It's a flu. It's a virus.
Okay.
And there's tens of thousands of strands. Influenza A is it's the main most common strand of it. Kind of like what do they call the master vampires, start things. You have break-offs,
No.
I don't know. But anyway, influenza A it's the main type of flu. Then you got influenza B, and then you got H1N1, you got all kinds of different influenza viruses. It's not fun. So actually, none of these, influenza A, SARS, pertussis, RSV, or COVID-19, none of those diseases has ever killed it. What the hell is he talking about? Truth of the matter is, none of those ever killed anyone. But they have led to respiratory deconditioning, which has then ended up with bacterial pneumonia, which then has led to sepsis, which has then killed people. Does that make sense? It's kind of like no one's ever died from AIDS. AIDS is a virus that destroys your immune system. No one's died from the AIDS virus, but they've died from pneumonia from not having an immune system because of the AIDS virus. Does that make sense? All right, let's go over epiglottitis. So epiglottitis does happen in adults, but it's pretty rare. It's common in kids. So how can you how do you know right when you walk in the door some kids got epiglottitis? Well, they're sitting forward, they're tripoding, and they're drooling nonstop because they can't swallow their saliva because their epiglottis is swollen and it's shutting off the esophagus and the airway. Do not put airways in these kids. Do not screw with the epiglottis, because if you make it swell more, it could completely shut the airway off. So if you tripoding, they'll be drooling and they'll have stridor for lung sound. Stridor is an inspiratory high-pitched sound. Yes.
Is this a call ALS?
Huh?
Would we call ALS for epiglottitis?
Yeah. One thing ALS can do for this, they can do a thing called nebulized epinephrine. And they can put all right?
Could you re-explain that, please?
Yeah. So they do is they nebulize epinephrine, which makes into a mist. Well, epinephrine is a massive vasoconstrictor. So it'll actually constrict the blood vessels in the abscess and it'll shrink the abscess. It's a temporary fix. It's not a cure, but it'll get you to the hospital. Any questions? Now, you're not allowed to do that, but if someone happened to have a private T mist inhaler and you sprayed it into their mouth, or the patient sprayed it into their mouth, it would pretty much be the same thing as nebulized epinephrine, because that's what a private T mist inhaler is. But I didn't tell you that in the private T mist. You used to be able to buy it in every store in the country. It's harder to find now. It's a nebulized epinephrine.
And you can get it.
You just buy it off the counter or over the counter. 0.3 milligrams of it's a meter dose inhaler epinephrine.
Okay.
People used it for asthma. Epinephrine was the nebulized epinephrine was the original asthma treatment. But it skyrockets your blood pressure and sends your heart running like a freight train. Albuterol does the same thing as that. Well, not the same thing. It's not as good of a bronchodilator as epinephrine, but it doesn't give you the racing heart rate, blood pressure. That's why most people take albuterol. You can still buy a private team mist over the counter. And you can still buy it from Amazon. You just don't see it in stores as much anymore. Any questions? Adult epiglottitis, wow. It's supposed to be probably an endoscopy showing you how big the epiglottis is. Yeah, it is. That's a bump sign. So you can see the vertebrae, right? And then his epiglottis, which is supposed to be tiny, it looks like a thumb. That's very bad. Trying to breathe as I'm trying to breathe through a coffee skirt. That's a pretty sick guy.
And where's the esophagus?
Esophagus posterior is the airway. So if the airway is coming down here, the esophagus is going down right here.
Oh, okay.
Yeah. X-rays generally light up bone, cartilage, and abscesses. They don't light up soft tissue that well or air. How you gonna breathe through that?
Very carefully.
Such upbeat.
Someone's about to die. So, here's our creepy kid with respiratory stridor. You gotta love medical parents. Your kids, the parents are EMS or doctors or nurses. Nobody else would video their kids while they're this sick. That's what stridor sounds like when he inhales. Got some accessory muscle built up there, little guy. That's called retraction, is what he's doing on his stomach there.
See something?
Yeah. Not fun. But now you know what respiratory stridor sounds like. All right, croup is most common in for kids that are 6 months old and 3 to 5 years. Older you get, the stronger airways get, the less common croup is. Telltale signs and symptoms are they're tripoding, just like epiglottitis, but instead of drooling, they got a seal-like bark with that inspiratory stridor. And they're very short of breath. Humidified oxygen and steam helps these kids a lot. Any questions?
What's our treatment? Just diesel and.
Diesel. And if you're waiting for an ambulance, you have mom turn the shower on, have mom go stand in the bathroom and have inhaled steam. The only steam that doesn't work on croup is anchor.
Oh. They're gone now.
I know. It's very depressing. There you go. Somebody get that kid a beach ball for his nose. Look at that diaphragm working. Any questions? On cost some more. Ooh, this Strider and a wheeze. Sick little one. All right, RSV can be very fatal if you don't have strong enough airways. And nowadays with the super RSV, if you're immunosuppressed, elderly, or overweight, it's probably going to be fatal too. Any questions? Whooping cough. Any questions? SARS. Again, it's just another respiratory virus. There's tens of thousands of them. Influenza A. Kills 60,000 people a year religiously every year. Questions? Anybody know what Captain Trips is? Don't worry, I won't get a test. All right. And bacterial meningitis. Lead to all kinds of problems, including respiratory. Can also cause neurological issues. Questions? Yes.
Isn't that, I always thought that was like entirely in the brain. How does it,
You can also get into your lungs, get into your spinal column.
like a fluid gas exchange? How does it?
Well, meningitis can be all over the place.
But it's not like a swelling thing, it's like something with the lungs.
Be in your lungs and your airways. But the good thing is generally it's bacterial, so antibiotics should kill it if you get to it in time. Yes.
So the difference between viral meningitis would just be the type of bacteria.
Yeah, viral meningitis, there's no medication for it. There's nothing you can do because it's viral. The bacterial, you can use antibiotics to kill if it's not bacterial resistant.
But essentially they're the same thing.
No, they're completely different. Bacteria is a different living organism. Viruses are a living host that spreads. That's a whole different thing than bacteria. Bacteria is not a virus. It's completely different.
I mean, like the symptoms and the way it functions in the body.
That, I don't believe there's any difference.
Okay.
But bacterial meningitis is very treatable, whereas in viral it's not.
Okay.
COVID. Millions and millions of people suffer from COVID every day. Just kidding, you know, not the COVID. What's COPD? Those are the 4 main types of COPD, but there's actually dozens of them. Emphysema is the one you're going to see around here the most. Most caused by the use of inhaled tobacco. Well, very close to having a chronic bronchitis is another one. Black lung, we really don't see around here. That's more of the mining communities, West Virginia. Biology. And then chronic asthmaticus, which is actually on the rise. No one knows why, especially in urban areas and cities. COPD is fatal 100% of the time. Might take 20 years, but it will kill you. Getting a lot of better medications that are keeping people suffering a lot longer. Inhaled steroids and such. Any questions? Now here's something we hope you really like.
Understanding chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult.
That Marl Wilbam picture it shows you the barrel
COPD is
chest.
the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
Any questions? Asthma, no fun. Asthma, when the airways spasm, your upper airways, and you can make air in, but you can't get air out. So you try to force air out, you hear a wheeze. It also fills up with mucus inside your airways and floods it. What we'll do in asthma is an episodic disease. People live completely normal lives until they have an attack, until a trigger happens. And when it gets triggered, then suddenly it can go from being perfectly fine, or what they call asymptomatic, no symptoms, to life-threatening, literally in minutes. So how do you know someone's having an asthma attack? They're tripoding, they have expiratory wheezing. You don't need a stethoscope, you'll hear it. And of course, they'll complain of shortness of breath. And sometimes they'll be coughing up white mucus too. That's another sign and symptom of, or sign, not a symptom of asthma. Any questions about asthma? Oh, so don't believe me, listen to this.
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. During breathing or respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into two large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of the airways, which clogs up the narrowed airways further and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack. Nation, visit www.nhs.
Any questions about asthma?
Yes.
Yes.
So it said it's not curable,
Nope.
but. Right.
Yep. Your airway strengthened and your immune system doesn't have the same triggers as you get older. As you get older, the trigger, your body realizes that's not actually a threat to you. Then you can also develop new triggers too.
Like, for example, and I grew out of it.
Or, I'll give you an example. I had really bad asthma as a kid too, and I also grew out of it. But then as an adult, if I didn't get a right amount of exercise and I tried to like really exercise, like run upstairs like that, I would start feeling asthma again. But if I exercise regularly and daily, that never happens. Yeah. Just from the strength of the airways.
So then, with the inhaler component, if somebody's having an acute asthma attack or first in the hospital, where does the inhaler fall short?
The inhaler usually falls short because they use a spacer.
Okay,
But
and assuming they use the spacer.
use the spacer, usually the inhaler works Wisconsin, so it
Oh,
causes
okay.
it causes smooth muscle relaxation, which dilates the airways,
Right,
and then the air can escape back out again.
okay, so there's not a circumstance though where it's like.
But my son had really bad asthma, and he could, by the time he was not even 3, he could use an inhaler with a spacer on his own. It's pretty impressive. And he'd go from sending a barking cough and hacking up unbelievable amounts of white sputum. And you would take a couple of hits off the albuterol and go right back to sleep, you'd be fine. Any questions? That brings us to congestive heart failure. It's like, wait a minute, that's cardiac. Why is it respiratory? Because congestive heart failure presents as dyspnea. So people used to die from this weekly. We don't see it nearly as much as we used to, and you guys now have incredibly good tools for it. Things I would have killed for when I was a young EMT. So with congestive heart failure, first of all, you got to understand what it is. And there will be a lot of test questions on it because it's still a big deal when you see it, even though we've got some good preventative meds now that prevent this from happening, as long as people take them. So congestive heart failure is when your heart is too weak and it can't pump the blood well enough. And so the right side of the heart's usually pumping blood better than the left side. So it causes kind of a traffic jam, it backs up, that's the congestion. So if the right heart's pumping blood, where does the right heart pump blood to? You gotta know this stuff.
Lungs, right?
What's that?
The lungs?
Yes.
Yeah.
Then the left side of the heart pumps body to the rest of the body. To the left side of the heart pumps blood to the rest of the body. So the left side of the heart is not keeping up the right side and the blood's backing up. Where's it backing up into?
The lungs.
The lungs. you start feeling short of breath, you start hearing rails because there's fluid building up inside the lungs. Then as the right side starts to fail, it starts backing up. So if the right side of the heart fails, where's the blood gonna back up to? Vena cava, superior vena cava, which go to the jugular veins, start becoming distended. And you'll start getting swelling in the feet. And your body will try to compensate for that by increasing the blood pressure. They'll skyrocket the blood pressure to try to make up for it, increase your heart rate. So you'll have hypertension, tachycardia, dyspnea. When you listen to lung sounds, you hear rails, you'll have jugular vein distension, and their foots will be swollen, both of them. You'll be able to stick your finger in and be indented. It's called pitting edema. Leaves a pit when you stick your finger in. Any questions? Yeah,
What is it caused by?
from your heart being too weak to pump blood. Heart attacks, dead tissue. Infarcted tissue.
Okay.
Makes the heart weak, makes it more jelly-like.
It can also be caused by bad valves.
Yeah.
One of your valves, that's what that.
Yeah.
Okay.
Ooh, is it reversible? No, not that I know of. I've read things that people have thought they've reversed it. They've done all kinds of surgeries and stuff. Outside of replacing a valve, if it's a valve problem. No, once the heart muscle is dead, it's dead. And usually you're on medication for life to prevent this from happening. Usually it's medications that are called beta blockers to stop your heart from working too hard, and diuretics that make you pee endlessly, to keep the fluid off, to keep the congestion, so the load, the volume load's not there to cause the heart to fail.
So if you got a heart transplant, that wouldn't fix.
Oh,
the
yeah,
problem?
heart transplant fixed
That
problem.
wouldn't fix it.
Those are pretty rare, pretty hard though.
Yeah, bad, no figure.
A healthy heart, as seen here, beats approximately
An LVAD will stop it also. A lot of people with full-blown heart failure will get an LVAD, which is a left ventricular assist device, which is a constant flow pump that runs blood out of your left ventricle and runs it constantly. Then you don't have a blood pressure or a pulse oximetry. Yes,
You know, they're making those that pulse now, apparently.
they're what?
They're making ones that pulse now, apparently.
I don't know anything about that. A pulsing LVAD, huh?
Yeah, apparently they, and I tried to ask why, because I was like, wouldn't it be better to do it the other way?
Yeah.
But
Well, I guess the reason why would be so you can still take blood pressures and pulse ox and all that stuff.
that's kind of the only thing it came up with, but
I wonder how the hell they do it with pulse stuff. I don't know.
The LVAD, it's just a mechanical pump.
Yeah, we're gonna go over it at the end of class. It's pretty, so a lot of times the ENT class doesn't believe me, they think I'm kidding, but LVADs are a real thing. And yes, what they do is they core out your left ventricle and they actually stick a pump in there. And it runs a constant flow pump back into your aorta. So you have so people walking around without a pulse. So you can't take their blood pressure, you can't take their pulse. Pulse oximetry doesn't work because that runs off of a pulse wave through your finger. And so there's no pulse oximetry either. And
What is it like that?
well, see, that's another thing too, is it's improving greatly. Dick Cheney survived 2 years on an LVAD. Used to be only like a couple months till you got a transplant. Now there's people on LVADs for years. Now I think the pumps usually outlive the people. They're stainless steel. And so we'll go over that in detail in special patients at the end of the class. But LVADs are a real thing.
Ever had somebody with an LVAD?
Yeah. Yeah, there's some matter of fact, our crews just picked somebody up with an LVAD, and I know the guy personally. I now have known actually three people personally that have LVADs. One's dead now. He was one of the first LVAD people ever. And he lived about 6 months with it. And then now there's a girl that's actually 3 years younger than me that's had an LVAD for a year. But she's still in the hospital. She's never gotten out of the hospital. But there's a guy living in May 10 right now that I used to work with, who's an LVAD patient that just picked him up. My crews picked him up the other day. I saw his name. It's like, oh, I know this guy. Then I read, it's like, oh my God, he's got an LVAD. Because they documented there's no vital signs because he's an LVAD patient. So.
Is it scary to run across somebody like that?
Yeah. Well, it depends. Like if they're unresponsive, because they're unresponsive, the only way you know they're dead is by capnography, is by doing the end-tidal CO2, because you can't You don't know if they have a pulse, you don't know,
Can you still get a systolic blood?
No.
pressure off of them?
because that goes off of the beat from the left ventricle. This is a constant flow.
Well, can't you, if it's a constant flow, can't you do the same thing with the thing, you start, and you slowly are cutting off the blood flow, and you see at what point it's.
No, because there's no way, you're not hearing the thump, 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 there is no thump, thump, thump. It sounds like an RX-7 engine, goes, "Bah." It's a rotary engine, that's what it is.
Do they have capillary recall?
What?
Do they have capillary-
Yeah, they have capillary recall.
So we normally have like medical tags or identifications.
Usually, yeah, and usually have a companion with them at all times, that can switch out the pump, switch out the battery. Because they run batteries, it used to be, they used to wear vests like this all the time, now they got them down, they're so small, they just wear a belt, the batteries and the controller on the belt. Then just goes into a drive cable under their chest. Pretty cool stuff. Don't believe me, Google it, hell bad.
No, I believe you, but this is like,
I screwed the EMTs to it so much, half of them got used for it.
I mean, imagine you get mugged.
Oh, that'd
The
suck.
guys, the guys like give you that on each other. No.
Give her the batteries, they're lithium. All right, here's a good video on congestive heart failure.
100 times. A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Any questions? Not a fun disease. So what we used to, high flow to keep them in a sitting position. What we used to have to do in severe cases, we'd have to bag these people while they were awake with BVM, stand behind them, push over their face, try to force area. Really uncomfortable. Most people would, if you had a fight on your hands. You guys have a tool now called CPAP. You put these people on CPAP, it's like turning a light switch on. They go from speaking one word sentence, not able to breathe, to, oh, I feel so much better, thank you. It's amazing. Because the CPAP immediately fills the lungs with air pressure, which then decreases the blood pressure, pushes all the fluid out of the lungs, saturations go up immediately. It's like a silver bullet, it surely is. Here's your signs and symptoms: dyspnea, hypertension, tachycardia, rails, JVD, fetal edema. I promise you, there will be test questions on these signs and symptoms. You have to know them. Any questions? Yes.
I'm still a little confused. So you put them on a CPAP and one of their ventricles failing,
Or both.
or both, and you're getting the circulation back. But how do
Actually, you're
you
decreasing
decrease
circulation.
circulation? Then how do you like, it's like a spasm thing that it just like stops basically like,
So what it's doing is
Yeah,
actually squishing the heart and squishing the freeload out. So your heart doesn't have to work as hard because there's not as much blood to pump. It's pushing it all back through the vein cable.
okay.
And then it's flushing, then it's pushing all the fluid out of the lungs.
Mhm.
So now you're getting better oxygenation. So then the heart's also able to work better because now it's got more oxygen going to the cells.
Okay,
It's stopping the doom loop of congestive heart failure.
gotcha.
Now, and second, then you take them off of that,
That's what I'm
they're
wondering.
gonna right back into it.
Right, yes, that's my confusion. Okay, so they then have to just stay in the hospital and sort all that out.
Till they get medications on that, stop the heart from overbeating
Oh.
and put them on beta blockers and things like that, get things situated, get them diuresed, get all the good, pee all that extra fluid off.
Okay.
What is this pH CHF,
So the depth loop is that the heart's too weak to pump, so then it overcompensates. Then it doesn't get enough oxygen, then the lungs back full of fluid, then it gets even less oxygen. And that's the doom loop of heading into
Wouldn't
even.
the heart pumping more, pump more blood out.
Right, but it's vasoconstricted because it's at a high pressure. So yes, you're getting more pressurized blood, but you're getting less perfusion because the very end cells don't get the perfusion because of the massive vasoconstriction when the blood pressure gets so high. So it actually kills more of the heart.
That starts to damage the heart. Okay.
One. She said 1 second, so I went back for 1 second.
You know us English speaking people like that turn of phrase.
Okay, I just came back.
I really went about it, the gas station, I was like, I'm gonna get something.
All right, spontaneous pneumothorax. Somebody asked me a question about this earlier today. And spontaneous pneumothorax are the most common in tall, thin, young males that are Caucasian, fair skinned, blonde haired. Y'all know Talon, right? He's the poster child for spontaneous pneumothorax. It's true though. If you start going, Talon, come here, stand up here. Yeah, I don't believe Talon's ever had a spontaneous pneumo. But every spontaneous pneumothorax I've ever been on looks just like that.
Why?
It's genetic. It's those are the people that get them. They have decreased connective tissue because they're so tall and so thin. That's something to do with that genetics.
But where does the air come in to allow the separation?
I'll show you. Don't let me tell you. Let me show you. That's right. Legs, drink flavored water. You guys hear that okay? Yes.
I think I speak for at least 3 of us when I say I have
No idea what that was about. So what it was saying was, yeah, that wasn't that great of a video. So what it's saying is when you got a tall, thin person with thin lining and the negative pressure increases the pressure that's already in the pleural space and can cause the lining to collapse, which then causes air to go in, which then collapses the lung. That's why it's spontaneous pneumothorax.
Is there a reason? Is there a reason why the air doesn't come back out?
Yeah, because there's nowhere for it to go out. It's coming from the lung, from the wall of the lung.
But when it comes into the pleural space, why doesn't when everything contracts, why doesn't it get pushed back into the lung?
Because it only goes one way. Yeah, I don't know why. So it's like a one-way valve.
All right. Well, it might be because we breathe in, everything goes out. Makes sense.
So the next one's pleural effusion. This is when you develop fluid. Majority of the pleural effusions you'll see are caused by cancer. Once in a while, it'll be from an infection of the pleural lining of the lung, but the majority of the time it's going to be cancerous, which really sucks. Most common cancerous type of pleural effusion is mesothelioma. She used to have a whole lot of commercials, but I think they ran that one bankrupt. Well, that's good.
Now you got Camp Lejeune.
What's that? Mesothelioma commercials? Yeah, they pretty much bankrupted the asbestos industry. Now they're after, was it Camp
Lejeune.
Lejeune? Yep. And AFFF. They're going after AFFF hard.
I mean, it's.
It was, but there's like massive cancer rates associated with it. They stopped making it. It was good stuff too. It worked fantastic.
They make commercial for that, don't they?
Oh, yes, of course, it's nonstop.
Yeah.
Oh, God. Social media.
I got to see those things all the time.
I can't look at my phone on a social media site without getting an AFFF offer to sue AFFF.
Well, it was always a big thing for the Bay Area, just dock workers.
Well, refineries,
Yeah, the refiners.
the main tool of the refineries, it's a class B firefighting plant.
On the pleural effusion, what are the lung sounds gonna be?
Diminished. Well, my wife's uncle had mesothelioma, and they actually would do a pretty cool thing. Because the way they treat this is they do a pleural tap, they stick a needle into your pleural space, and they pull it off. What they did with him though, which I thought was a pretty good idea, was they just left to drain it to the back. Then you just drain the back. I think that for maybe 1 or 2 years. Whereas in usually mesothelioma, it's just death sets to kill you quickly. But
What does it do?
Hello,
Does it-
this is Dr. Carlo.
creates the pleural effusion, this fluid just crushes your lung. So what they do is they go and they tap it, they do a pleural tap, they pull the fluid off with a syringe and a needle. But what they did with him was they just left it in there, they just left the drain hose going into a bag, and they just drained the bag. This problem is when you do the pleural tap, it refills the fluid 2 or 3 days.
Okay. Why does does it just leak fluid into the pleural space?
Yeah, it's a byproduct of the cancer, kills you.
Okay.
Emergency physician and founder of edxitvideo.com. This video is about pleural effusion. A pleural effusion is a buildup of fluid between the layers of tissue that line the lungs and the chest cavity. This picture is the blue area on the bottom left of the picture. Your body produces pleural fluid in small amounts to lubricate the surface of the pleura, the thin tissue that lines the chest cavity and surrounds the lungs. Pleural effusion is an abnormal, excessive collection of this fluid. There are 2 types of effusions. Transudative pleural effusions are caused by fluid leaking into the pleural space. This is caused by increased pressure in or low protein content in low blood vessels. Congestive heart failure is a common cause. Exudative effusions are caused by blood vessels like inflammation, lung injury, and drug reactions. Symptoms of an effusion include chest pain, cough, fever, hiccups, rapid breathing, and shortness of breath. However, sometimes there are no symptoms. Signs and tests. During the physical examination, the doctor will listen to the sound of your breathing with a stethoscope and may tap on your chest to listen for dullness. The following tests may help confirm a diagnosis. A CT scan of the chest will show a loculated pleural effusion you can see on the left side of the chest. A plain chest x-ray. In this picture, you can see the heart is blunted by this white density on the left side of the chest, the right side of the picture. This is pleural fluid. Pleural fluid analysis. Examining the fluid under a microscope to look for bacteria, amounts of protein, and presence of cancer cells. A thoracentesis is the procedure by which we put a needle into this cavity to drain the fluid. Treatment of a pleural effusion aims to remove the fluid, prevent the fluid from reaccumulating, and treating the cause of the fluid buildup. A therapeutic thoracentesis may be done if the fluid collection is large and causing chest pressure, shortness of breath, or other breathing problems such as low oxygenation. Removing the fluid allows the lung to expand, making it easier to breathe. Treating the cause of the effusion then becomes the goal. For example, pleural effusions caused by congestive heart failure are treated with diuretics, water pills, and other medications that treat heart failure. Pleural effusions caused by infection are treated with antibiotics. In people with cancer or infections, the infusion is often treated by using a chest tube for several days to drain the fluid. Complications of pleural effusion include a lung that is surrounded by excess fluid for a long time may be damaged or injured. Pleural fluid that becomes infected may turn into an abscess, also called an empyema, which will need to be drained with a chest tube. And the pneumothorax, which is air in the chest cavity, can be a complication of the procedure done to drain it. If you are diagnosed with a pleural effusion, but the underlying cause has not been identified, then it is most important to follow up so more tests or procedures be done. If you have fever, chills, increasing shortness of breath, chest pain, or feeling faint, if you have any new or any progression of the symptoms seen the first time we evaluated you, you should come back to the emergency department. For more videos like this video, please go to ED Exit Video.
All right, status epilepticus, that's when you have a seizure that doesn't stop. When you're seizing, all your body's muscles are contracting, so your intercostal muscle, your diaphragm are not breathing adequately. That's why after 2 to 3 minutes of a sustained seizure, they start turning purple. You do not send the burning zone. Any questions?
And is, what triggers this? Is like a brain tumor situation?
Epilepsy or seizures can be caused by hundreds of different things.
So it's not a specific type of seizure that results in staff.
You know what epilepsy is?
Yeah.
You doing, what is it?
Huh?
What is it?
It's a wide variety. It could be like grand mal
Yeah,
absence.
no, it means we don't know why they're having seizures,
Yeah.
but they have seizures and we can't control them.
Mhm.
That's what it means, to catch all.
Okay, but it's not like the side effect though of like particularly. not
Yeah, no,
particularly-
status epilepticus is when they start seizing and they don't stop. Usually most seizures stop after 30 to 90 seconds.
Mhm.
Status epilepticus keeps going 3, 5 minutes, 45 minutes until they die.
Oh, gotcha.
Yeah.
Okay.
It's a true life threatening situation.
How do you personalize?
Better Versed or Valium, CNS depressant medications.
Mhm.
EMTs can't do it. You give them measles, you get someone that can give a CNS depressant. Ativan, Versed, Valium. All right. This one unfortunately is way too common. You're gonna see way too many times.
It says blood clot that blocks B.
What's that?
It says blood clot that blocks B.
Yeah.
Okay.
The beach. So anyway, it's a blood clot blocks blood from getting to the lungs. So blood can't get to the lungs, how does it exchange gas? It doesn't. What happens if you don't exchange gas? You die. So this happens in young people, it happens in old people, it happens in all types of people. There's a lot of risk factors. The more combined risk factors you have, the greater your chances of throwing a pulmonary embolus. Signs and symptoms are sudden onset of shortness of breath or dyspnea, chest pain, and a continually decreasing oxygen saturation level. Clots usually start in your leg, travel up through your vena cava, go through your right atrium, go through your tricuspid valve, through your right ventricle, through the pulmonary valve, down the pulmonary artery, and then lodge in one of the smaller pulmonary arterioles.
And that just doesn't allow enough.
Doesn't allow any blood flow. Once it blocks those arteries, none of the blood distal to that artery can be exchanged for gas.
Okay.
So you start feeling immediately short of breath, you start having chest pain, because there's not enough oxygen getting to your heart. And it's usually not one little clot or one big clot, usually it's multiple little ones breaking free and going, and it just starts filling them up. They die quickly. Oh, yeah, and even then, there's very, very little that can be done. They can go into interventional radiology and do a thrombectomy. But man, that's hard to time and get to a place that's got it. And you actually have an interventional radiologist in house, and pretty rare that they're able to pull it off. Sometimes they can put them on a drug called heparin and try to buy them some time, because heparin will dissolve the clots coming off the leg. But it's a pretty tragic condition that happens, unfortunately, daily in this nation.
That was just
Yeah. Or even within minutes sometimes. I know some people were it's killed literally in minutes, some people it's killed over a few hours.
nothing hospitals can really do.
Matter of fact, it used to be, it may still be one of the leading causes of death in hospitals. Post surgeries.
Oh, because like,
Because they're said there's a lot of reasons. So one of the things is when you're healing, you have increased clotting, so that increases increased blood clots. Then if you're sedentary, you also produce blood clots. After you have surgery, you're not getting up and walking. You've been sitting for days, and people get up and walk around, then it throws a clot, goes into their lungs, they're dead. That's why a lot of times when you visit the old hospital, they got those stockings on that are pumping the airs up, squeezing their gaps. That's what it's doing, is breaking up the clots so they don't form. Trying to prevent that.
and those are, sorry,
And that's why they make you walk around, yes.
and those clots just build up while people are healing because the blood's just stagnant, or, okay.
So then your risk factors are sedentary lifestyle, healing, cancers or any type of disease, healing from fractures or major trauma, which is surgery. Yeah, you have surgery, that's a major trauma of the body. Other risk factors, birth control pills, because it increases the fatty supplies because it makes you think that you're pregnant, which gives you to store fat, which then also stores clots. Nicotine use, any type of nicotine use is also a factor. And what else? I think that's it. And of course, one of them, or being overweight is another one. Age is another one. But any one of them is bad. If you start having 2 or 3 or 4 of them, it's pretty much a death sentence. Use of any fight or flight stimulants like methamphetamine, high dose caffeine, things like that. Yes.
AFib a risk, or does it never really make it back?
AFib is a risk because AFib causes clots also due to the, but usually that's arterial clots, which cause you to stroke. They'll go up through your carotid artery and lodge in your brain and stroke you out.
Well, I was wondering if
It's the other side of the circulatory system.
So hospitals, they can't get into the veins or into.
Well, I said, if they have interventional radiology and they're in-house and they're right there to stop it, yeah, that's pretty rare. You're talking less than, you're talking all the stars have to be aligned perfectly for that to happen. They don't generally have interventional radiologists in-house, usually they're at home watching x-rays on their computer at home, TV.
Interventional radiologist.
Yeah. So an interventional radiologist is a radiologist, got a person who looks at x-rays and radiology. But they're also a surgeon that can go in and watch, they can go into the body while the patient's under radiology and remove things on camera through radiology, like going in and pulling clots out of a circulatory system.
So is there any reason it's different than like for when someone has a stroke?
No, strokes, they also use interventional radiology to try to go in and get the clot, or they'll give a drug that tries to dissolve the clot.
Okay.
But the drug, for some reason, they don't use it in pulmonary embolus. I don't think there's enough time. It goes too fast.
Okay.
Whereas in stroke, you've got 90 minutes to 6 hours. With a pulmonary embolus, you've got minutes, so there's just no time. So interventional radiologists are few and far between. Like Fairchild flew someone to Vegas the other day for interventional radiology. They had a gallstone stuck in their bile duct. And the closest available interventional radiologist was at Sunrise Medical Center in Las Vegas.
Seriously?
Yes. So yeah, so the chances of you having a pulmonary embolus, getting an interventional radiologist to pull it out in 10 minutes is nil. So one of the most tragic ones we see in Siskiyou County is females on birth control who use nicotine. And it happens every freaking year. You die of a pulmonary embolus, they have a massive stroke. And it says in
If
big
you
bold
are
print on
immobile for an
the birth
extended
control bottles,
period of
do not
time
use with
because of
nicotine.
surgery, pregnancy, illness, or travel, you may be at risk for deep vein thrombosis, or DVT, a condition where a blood clot forms in a deep vein in the body, typically the leg. Unlike arteries, which rely on the heart to force blood through them, veins transport blood with the help of muscle contractions while you move and walk. Veins also have valves that keep blood from flowing backward and pooling in your arms and legs. When you are immobile for an extended period, your venous circulation slows down. As a result, clotting factors in the blood may cause the slow-moving blood to clump together, forming a blood clot or thrombus. This condition is called deep vein thrombosis, or DVT. Common symptoms of DVT
DVT, you
include
gotta know for the
swelling of the
test.
leg or a vein in the leg, pain or tenderness in the area, increased warmth in the skin, and red or discolored skin. In some DVT cases, a blood clot may detach from a deep vein and join the bloodstream. The clot travels from the deep veins of the leg through the veins of the abdomen into the heart, and finally lodges in the pulmonary artery or its branches, blocking blood flow to the lungs. This condition, called pulmonary embolism, is very serious and may permanently damage a portion of the lung. If the clot is large, or if there are many clots, pulmonary embolism may also cause death. If you experience symptoms of PE, please tell your doctor or nurse immediately. These symptoms may include shortness of breath, a sudden sharp pain in the chest, a feeling of lightheadedness or dizziness,
Started with leg
rapid
pain.
or irregular heartbeat, or coughing that produces blood. To help prevent deep vein thrombosis and pulmonary embolism, your doctor may require you to do the following. Walk around periodically to keep the blood from pooling in your legs. Wear compression stockings and take anti-clotting medication.
There's your risk factors. Smoking, one of the biggest ones, yes.
How long would somebody need to be like sedentary?
Days.
Okay.
Some, depends on your age. Some people throw peas on international flights. Especially if they're using nicotine on international flights, yeah. People over the age of 50, a lot of times their doctors will prescribe them blood thinners to prevent clotting. If they know they're flying overseas, they're gonna be sitting for like 14, 16 hours.
Why is nicotine so bad for it?
Nicotine is a massive vasoconstrictor.
Okay.
So it makes the clots lodge. So like a little tiny clot that would cause like a minor problem. If you're using nicotine, it can cause a major problem because now a major artery is the size of a tiny artery. So it kills even more. It increases the death rate of cells by astronomical. So smoking, post-surgery, any sedentary lifestyle, people that just don't get up and move around, generally from chronic illness or chronic injuries, birth control pills, recent fractures, cancer, prolonged bed confinement, and of course, clotting agents. And of course, the older you are, the better the chance of it happening. Any questions? Yes.
Why, when you get hurt or have major trauma, does your blood like increase the clotting factor?
Yeah, that's how you heal.
Okay, so it's that increase of clotting factor, it's lodged.
Then you have the sedentary because you've been injured or you're sick. Then you got the increased clots, and then you have the prolonged bed confinement. Yeah. And then it doesn't kill you then, it kills you when you get up to walk over and go to use the bathroom or get a drink of water. Then the clot breaks free and done. We used to get, don't see it as much anymore, but man, we used to a couple times a year get a dead body in the parking lot of hospitals. It's common. They walked out, you used to hear the stories, they walked out of the hospital and dropped dead. That's what they did in the hospital for 10 days. And they walked out and they threw up BVT and deep vein thrombosis came up, went into their pulmonary artery and killed them. Tragic. These are very, very tragic.
So what are the ways?
That's what they went on the video. Walking, don't smoke, don't take birth controls, don't get cancer. Don't have major operations, don't put yourself in those positions. But if you do, that's why they try to get you up there after surgery, try to get you up and moving the next day.
Okay.
And it's very important. Don't live a sedentary lifestyle. Another big industry thing is truckers get pulmonary embolisms. They get overweight and they sit all day long and then they jargle the road jargoning and it knocks the clots free. And
Would somebody pregnant as well get a reduced crack?
yes,
Okay.
but only during the pregnancy.
Okay.
Because they're doing increased fatting and clotting stores. After you have the baby, that should stop.
Why does the spotting happen?
It's the increased fatty stores. So you can get fat too. And it could be an embolus.
The body?
If you store fat, your body stores fat when you're pregnant, so you can use it for energy and fuel for you and the baby.
Okay, and then that increases the blood factor?
Or the fatty factor, you can run fatty embolus breakthrough.
Okay, and then it just increases the clotting factor, so the body, or,
Not that I know of. I know they have fatty embolisms too,
okay,
so I'd have to go research that a little more.
but it does increase the
Pregnancy and birth control definitely increase it.
cartilage.
I know females taking birth control and smoking over the age of 40 is pretty much death sentence. The risk is astronomically high.
So just beat it.
Walk around every day. Carbon monoxide poisoning. This is another big one in Siskiyou County. It's colorless, odorless gas. Your hemoglobin that bonds to the oxygen to bring to your cells likes carbon monoxide 200 times better than it does oxygen. It's generally inhaled through a byproduct of combustion. Generators, car exhaust, wood stoves.
Reads it the same, right?
Because all a pulse oximetry is red and white light shined against the pulse wave and it measures what's reflected back to the oxygen hemoglobin. So when it takes, so carbon monoxide is one oxygen atom instead of two oxygen atoms. So it's reflecting the same oxygen atom. So you get carbon monoxide, was you get 100% O2 set, but they can't breathe. Because it's not red, it's a false reading, is what it is. It doesn't, they haven't come up with a pulse oximetry yet that can read two atoms instead of one.
Yeah, so it shows light and that light bounces off the hemoglobin.
And it reflects how much comes back, that's how it knows what the percentage of hemoglobin is inside your bloodstream.
But it's not actually, does it measure the difference between hemoglobin with carbon dioxide combined to it, or?
No, because carbon dioxide doesn't reflect, but carbon monoxide does, because it's an oxygen atom, just like
Okay,
O2
and
is.
oxygen also.
It's one oxygen atom instead of two oxygen atoms combined. So they haven't come up with one that can tell the difference between one and two atoms. Any questions? Highly fatal. They'll generally have a cherry red complexion. They'll act like they're drunk, or they'll just be completely unresponsive.
Why do they get triggered?
It's the same thing. It's a byproduct of the blood having a lot of carbon monoxide in it. It makes the skin red. Just like arterial blood's red.
Can you say someone that has it?
Yeah, if you can get them out in time and put them on high flow too, and sometimes BiPAP or CPAP. and get the carbon monoxide out of the blood, get it replaced with oxygen, yeah. BiPAP is like CPAP, but there's not a constant pressure, it only gets pressure when you do a negative inhalation. And then it supports the negative inhalation. We've had cases of it here, 4th of July one year. Had a report of a guy drunk at the parking lot of Sports and Spirits and Rite Aid. And the officer showed up, thank God the officer was a really good EMT, that had also been a firefighter before he was a cop. And he noticed there's no smell of alcohol in the guy's breath, and he had a cherry red face. He asked him, I didn't know who he was, where he was, didn't know what town he was in, was stumbling around the parking lot. And so, well, you know, what were your plans for the weekend? He says, planning on going to Mount Shasta 4th of July. He goes, we're in Mount Shasta. He goes, oh my God, where's my family? He goes, well, where would they be? He goes, in our motorhome. He knows there's a motorhome running behind Sports and Spirits. He went in and sent in, the entire family was unresponsive. The cop was able to pull them all out. But they were at the maximum level. If they'd have been in there probably another 30 minutes, they'd all been dead. Yeah. And what it was, they had a generator running on the motorhome, and it had blocked the vent, the flue vent, and it was going up, the exhaust was going into the motorhome. MRSA. MRSA will eat you alive. So there's massive, and I mean massive, miseducation throughout the entire healthcare industry on what MRSA is, how it spreads, and what you do. So pay attention. This includes nurses. There's an entire unbelievable amounts of nurses that have no concept of what MRSA is and how it spreads. So by the time you are done with this class, if you've done your 24 hours observation time and had 10 contacts with patients, you will be MRSA positive. I promise you. There is no way you cannot. Anyone in the healthcare industry has MRSA. It's a hazard of the job. We all have. So that's the bad news. The good news is we all kill it. Our immune system kills MRSA, but we're still a host. We still carry it. So where you have a problem is when you have active MRSA. So generally, when we get exposed to MRSA, our immune system recognizes it and goes, kill, kill, and it literally kills it in minutes. So it's not a problem for us. So where you run into a problem with MRSA is when you have a patient that has a case of active MRSA. So their case of active MRSA, when you get exposed to it, your immune system is going to kill it, as long as you're healthy. If you're not healthy, your immune system's not working, then you're in big trouble. But anyway, you'll kill it. However, the active MRSA will live on the linens of your gurney, the equipment, on your clothing, on your gloves, or anything that you've touched for 72 hours, 36 to 72 hours, I believe. You can read in your book, it'll tell you the exact number, so you don't remember. Longer than it should. So where MRSA is a problem isn't that it's a problem to you, it's a problem to your next patient. You don't completely disinfect everything that patient has touched, the equipment, the gurney, the knobs, the door handles, everything that you touched and everything that patient touched. If you do not disinfect all of it, and then you have an immunocompromised next patient, an elderly person, a really sick person, and they come in contact with active MRSA, it will eat them alive and kill them. That's why MRSA is a big deal.
And it has to be active MRSA, you can't.
Right, you can't kill it just with your own, you're not Superman, you can't go, oh, kill it. You gotta use it.
I mean, like for us, if we get MRSA.
We get MRSA, we're in big trouble.
Why do you have?
Yeah, passive MRSA where you're just, your body's gonna kill it, it's not a problem.
Okay.
It's not gonna make you sick,
Are
it's
we
not gonna
still
eat your
give off
flesh.
MRSA, or do we give off MRSA?
If you have active MRSA on you, yeah, you'll kill it, but you can give it to somebody else.
Active, not passive.
Correct.
Okay.
Correct. But that's the thing is active MRSA lives way too long on objects and on clothing and things like that. Flesh.
What is duty?
Eats your flesh, literally. Eats you alive.
Is it like a virus or?
No, it's bacteria. It's methylocin resistant Staphylococcus aureus,
Wow, that.
like staph on steroids. Any questions about MRSA? So you bring an active MRSA patient into a nursing home and no one knows it. I mean, you could wipe out 30, 40 elderly people in a week. And talk about getting some open beds.
Then how do you tell if somebody has MRSA active?
You'll see their flesh eating away, rotting away. You go, ooh, we should probably test that.
Are we gonna have some pictures?
MRSA pictures?
That'd be great.
That'd be great. Not sure if we should put that, but I would like to see it.
Track your stuff. There you go. You should be okay. You'll kill it.
Should we take any extra precautions? That's sort of aside.
Yeah, so if you know you have an active MRSA patient, depending, you should have a protocol for it. Any agency you work for should have an operating procedure for MRSA. A lot of them will actually take stickers and put MRSA stickers on to remind everyone that it has to be completely disinfected, that you don't take the stickers off until whatever that is disinfected. And if you're going into a facility, they've got to make sure that the facility knows they can put that patient in isolation, especially if it's a nursing home or a hospital. Any questions about MRSA?
Is it spread through like direct contact? With it?
Huh?
Is it spread through like direct contact?
Direct
with it?
and indirect,
Okay.
both. Yeah, because it lives on indirect surfaces for way too long. Next one, tuberculosis, same thing. Tuberculosis spreads like wildfire, but it is an airborne virus. Someone coughs particles into the air, you inhale the car particles, and you've been exposed to tuberculosis. So again, a lot of people can be exposed to tuberculosis, their immune systems can kill it, but they'll be a carrier the rest of their life. That's why you gotta have a TB test before you do your ride-along time to make sure that you're not a carrier. Yes.
Oh, so if you've ever had TB,
If you're on TV, you'll test positive the rest of your life.
and you'll always be getting on TB.
You'll always be a carrier. You may not, you said that you gotta be active to give it to somebody.
Okay.
But if you test positive, you'll test positive the rest of your life. So anytime that someone requires a TB tester, you'll have to have a chest X-ray with blood draw to prove that you're not positive for the rest of your life.
Like you're not active? or
Yeah.
you're not positive? Okay.
You have to have a blood draw and a what?
Chest X-ray.
Oh, okay.
Yeah, because tuberculosis, an active case of tuberculosis, college campuses, as an instructor here, we got to be TB tested every 3 years. But college campuses, hospitals, clinics, or you have a large combination of people in close range, tuberculosis spreads like a prairie fire.
You have tuberculosis, you work in healthcare, is there a certain amount of time you always have to get it redone?
Usually once a year. Or if you get sick, they test for it, especially or cough and blood, hematitis.
Is that just because it can come back?
Yeah, because it's bacterial, so it can always come back.
So if you get it, fight it off. And
Still come back. It's not a virus.
still be the same. Okay.
It's not a virus. Virus is generally your body or your immune system remember it, know how to kill it. Bacteria, you can get again and again and again. Question.
So I know people that get the TB test, but they, like my dad, was born in Mexico, he got that BCG. How is it that it comes as positive free,
Right, always. It will the rest of his life.
just because that BCG?
What's BCG?
They shot to get right at your newborn.
Oh, it's vaccination.
Yeah.
Yeah, and he'll always test positive. That bites.
So
They used to give out a vaccination for TB.
No, it's a different type of vaccination. I don't know what it's for. I've heard of that though. I know vaguely what you're talking about.
It's the same thing.
they make us big
What's
ones.
BCG?
I don't know, but it's the same thing. She'll see if it's also,
Every year she gotta have chest X-ray.
but yeah. But that little thing that they gave to us, it's severe. Yeah,
So it's a vaccine they use in Mexico, but not in the United States.
and it leaves like a little mark on your shoulder.
Oh, that's the what's the whoopee cough? The
Bacille,
yeah, we got the same thing here. But it doesn't. Oh no, it's a TB vaccine. So what it does is it teaches your body how to kill a bacterial disease. That's actually pretty impressive.
Yeah, it's weird because they're like, oh, you have TB. No,
No.
I had it.
Right, I got the vaccine.
My whole entire life, I don't have it, I have it. So,
Right, and she'll kill it every time it comes in because that's how that vaccine works.
So why don't more people get it?
Because it's not prevalent in the United States.
Yeah.
We knock it out because of ours. Our healthcare quality is so good that it's just not. And probably the pharmaceutical manufacturer has not invested billions into lobbyists to get it required. That's the real answer.
So whenever like that gets the TV set, they make them do that whole blood work at
An
X-ray.
X-ray.
He never has it, but he has. to-
Right, well, and he won't because he's vaccinated. His body will kill him.
You can't just show them a proof of vaccination.
No, I think about that right away.
Bureaucracy, come on.
You have to get it to travel, because I know there's certain ones.
Not that I'm aware of.
No.
Not that I'm aware of.
Yeah, but if you go to Korea, there's like 18.
All right, pneumonia. So that's the big thing we worry about with the end result of all of these respiratory viruses and bacteria is developing pneumonia. Pneumonia is the end game. This is what kills you. Any one of these things we went over tonight will eventually lead to pneumonia if not treated or if your immune system doesn't kill it. Pneumonia goes untreated, it'll end up in septic shock and they'll die. So it starts with flu or cold-like symptoms or the symptoms of any typical upper respiratory virus or lower respiratory virus. You start getting rales on one side, unilateral rales, which is where the infection is inside the lung. Pneumonia is an infection of the lung. And you'll get signs and symptoms of septic shock, warm flush in the skin. You'll get real weak. You'll start coughing up yellow and green stuff. You'll get weaker and sicker and weaker and sicker and weaker and sicker until you die. Or you beat us.
So whenever I was there was a guy.
That's because he vomited and then inhaled the vomit into his lungs. He's still in really bad shape. Pneumonia, absolutely. Antibiotics, steroids, vasopressors. He's actually down in St. Helena right now, and they're hoping he'll be home by Sunday. If he continues to improve. All right, let's learn about some lung sounds. Rails, bronchitis, and wheezes. Sounds like a country song.
Abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Stridor, a harsh, high-pitched sound heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
One second here. All right, Strider.
Hello, it's Wes. Sean Wes is. In this video, I want to discuss stridor. Stridor is caused by narrowing or obstruction of the upper airway. Stridor is wheezing, and it's usually heard during the inspiratory phase, whereas in this diagram, this is the inspiratory phase, and this is the expiratory phase. These little lines, wheezes. So during inspiration, stridor can be heard without a stethoscope. It originates from around the pharynx and the larynx. So therefore, it can be heard during inspiration without a stethoscope. You can hear it standing next to them. And sometimes you can hear it on exhalation too. The causes for this are croup, that's very common with pediatric patients, along with the barking when they cough. It could be a foreign body in their airway. They have a nickel in there and it's turned a little bit sideways. That'll cause stridor. A tumor growing in their airway. It could be some sort of inflammation in the upper airway. One example here is epiglottitis. There is viral and bacterial epiglottitis. One is very, very dangerous. If you are not sure what the cause of this is, do not inspect the airway. Don't get your tongue depressor. Don't touch anything in your oropharyngeal airway, just so you won't cause any further inflammation or occlusion. Common treatment for stridor and its different causes are inhaled corticosteroids, systemic corticosteroids, inhaled racemic epinephrine, or adrenaline. In any situation, stridor is a sign of a serious medical condition and should be seen by a doctor in the emergency room as soon as possible. Okay, thank you so much for watching. Bye. Wes. Super Wes, that is. In this video, I want to talk to you about the breath sounds that are often referred to as rales, bronchi, and crackles. Which is which, what do you use for more practical purposes? When you're actually working and charting and giving a report or making it off the phone, this more accurately describes what you should be doing. Rales and bronchi are a legal term. Nobody really knows what they mean. The term you should use is crackles. But there's three different things you should include with the term crackles. First, the type of crackles. Are they fine crackles? Are they medium crackles? Or are they coarse crackles? Who do you hear them? You hear them during inspiration. You hear them during expiration. What part of inspiration and expiration do you hear them? And where are they? Right low, or they whole left side? Good description of breath sounds. Crackles happen when there is air passing through and around fluid and mucus in the lungs, brainstem, bronchus, or upper airway. An exception to that is atelectatic crackles, of course caused by atelectasis. Atelectatic crackles are fine crackles in the end inspiratory phase, and they're usually in the lower lobes. My diagram here shows inspiration and expiration. Fine crackles sound like Velcro ripping apart. It could be atelectatic crackles, or they might be the beginning of fluid overload or pulmonary edema. Usually scattered about, and the fluid getting more built up or the spoon breath. Coarse crackles. Usually when there's a lot of fluid present, Who knows about crackles? You hear crackles and you can see somebody's chest. It's in the upper airway, the nose, the back of the throat, it will echo all through the lungs. So ask them to clear the throat. And also the flames in their chest. Ask it off. So it resolves itself. You don't want to disregard it because you're able to talk about it. But try to think if they were able to clear it out. It's saying what the flame look like. Also, if your patient has an endotracheal tube or a trach tube, crackles are not normal breath sounds. They should have clear breath sounds just like everybody else. It's usually when you clear it out and you talk it up, and if we did section of the tube. So just to summarize, the crackles are either fine, medium, or holes. But and then happen in inflation or exhalation, and whatever they have in the lung. Okay, thank you so much.
What's that? Yeah, wrong hair. Higher up. Any questions about what wheezes sound like? We already did CPAP, didn't we? You already have this? All right, case study. You're dispatched to unknown medical. What do we do first? You guys cheated. What's next? Primary assessment. Early 20s field severe distress. She's learned to can only speak one word sentences. Is that an adequate breathing?
No.
No. Airways clear. She's breathing 32 breaths a minute. She's turning blue. What's next? Yes. What's the next step in the assessments? You begin assisted ventilation. Now what do you do? History. You cheated. Patient can't give you history because she can't talk. What's next?
There is someone who can't.
Yep. So, oh, look at that. Somebody who could talk. Her boyfriend's on scene. States she got a short breath during an argument. They're arguing about, or no, says that she's allergic to have some antibiotic shellfish. Her history is all history of the expert. She had a grilled cheese sandwich 25 minutes ago. They had a fight just at dinner because he cooked shrimp for herself and a grilled cheese sandwich for her. She was being short of breath during the argument, can't turn blue. What happened?
Both in the same.
Her boyfriend's an idiot.
I was gonna say he's a nice guy for doing all that.
Almost killed her. All right, any questions? All right, go to break, be back at, after that break, we're gonna go into caffeines.
Ready, man?
Yes, ma'am. Yeah. Feeling nauseous. All right. Yeah, go. Make sure you're back Thursday, though. Don't want to miss your test.
You're gonna call Ralph. So with that last question, I texted you.
Yeah,
I.
I already explained that in class, huh? Yeah, COPD doesn't have JVD.
COPD doesn't have it?
COPD does not have JVD. There's no obstruction that causes blood to back up the heart.
Well, then that makes sense, but. Someday, it's a good question.
Hey, welcome back.
I know.
But when we listed out, it was like.
How you doing?
No,
Same
I'm
stuff.
not going. I took a test.
Oh, got it.
Was he taking that? It came into
Well,
Texas.
no, see.
Hello. Oh, so it was an econ.
Yeah.
Does that make sense?
We're week
so.
4. I think it's an average.
You know,
It's a big week off.
cards
for
to
everybody.
those there.
So it's 8 weeks, but there's a week missing.
Over.
No, I'm not.
I don't know if I should do skills,
Why?
because I don't want anyone to touch me, because I'm still really kind of sick, and I don't really want to touch anyone.
I have them organized by.
I mean, I can observe, but I don't think I should participate.
All right, stay in the.
Okay.
You can be the scribe.
You know, two.
So she was. Playing allergic reaction. Yeah.
Would that continue to?
Sure. Allergic reaction trigger. She's still the cause of the day. Welcome.
Oh, my God.
Yeah.
Look what the wind blew
We're
in.
getting it all started asking. But she was probably still getting exposed to cosmic agents, so it's continuing to.
Also, that's not like a good, like.
Right, if she's still in contact with whatever's causing it, it's going to continue to cause it. It's not us, it's the insurance operator. We want to have, it, of course. So yeah, so it's gonna continue. For instance, we were talking about this morning, my son, when he was little, was allergic to cat, but we didn't know it, so we kept getting pneumonia because he kept having allergies. And we kept putting the cat food to make him feel better.
Yeah.
That's why he never got better. And finally, we had to take him down to Chico to an allergist. He goes, he tested, he goes, he's highly allergic to cats. It was like, oh, shit. They always got rid of the cat, never went to the hospital again.